right there. My hair is pulled back, my mask is on, and my surgical assistant is ready with irrigation. This is probably an implant patient. We have the motor and the surgical kit, and you couldn't drag me out of that room with a Mack truck. I'm in there, I'm doing it, and it really does bring me tremendous satisfaction. I started this journey, actually, I started this journey in college. I was a psychology major. I graduated from Wesleyan University, which is in Connecticut. And as a psychology major, I took my pre-med prerequisites to allow me to be able to eventually become a doctor. I didn't know what kind of doctor. Funny little thing is that as a psychology major, I took architecture and I took sculpture. And a lot of the sculpture tools were dental tools. And I was like, these little things, they fit really nicely in my hand. I can carve the clay with them. I can, transform mold into actually producing something. So in college, my father encouraged me to go to dental school. At first, it was really far from my mind, but um, it worked out, not to say the least. And so I graduated from Temple University School of Dentistry, which is now the Kornberg School of Dentistry. It was really hard and it was really challenging and it was uncomfortable. And I was absolutely miserable. Dental school was a miserable experience for me. But the silver lining was the day that I got to take a tooth out, and I knew that I was in the right place at the right time, doing the right thing. From there, I decided, well, I wasn't ready for a 4-year program just yet, but I was going to at least purposefully be in an oral surgery environment. It was never a thought to be in a GPR or AGD. I don't do anything about cleaning teeth or fixing teeth. That was never anything that I was interested in. So I was accepted to a 1-year program internship at Brooklyn Hospital Center, which then became a 2-year internship. And it was the best time of my life, running around. I lived in a high rise in New York, Brooklyn, New York. And the high rise, maybe I was on like the 15th floor, but I would take the elevator down and we could cross over to a bridge and get into the emergency room. It was connected on the 2nd floor. And so that was, I mean, how easy could it be? So if we'd come down, we'd see a patient in the emergency room, maybe he was drunk or maybe he was assaulted, combative, broken mandible. So we'd say, okay, let him sleep it off till he can communicate appropriately. And then I'd go back up to my 15th floor, I don't want to say penthouse, but it was a very nice apartment. And then I'd come back down to the emergency room. So, I mean, life couldn't get any better. My home and work were literally in the same building. And I learned so much and just really immersed myself in oral surgery. And so then I got accepted to Howard University, a 4-year residency program. And the beauty about Howard's program is that we rotate to different hospitals outside of Howard. We had a rotation at Georgetown University with Dr. Jeffrey Posnick. He's a world-renowned craniofacial maxillofacial surgeon. We had rotations at Washington Hospital Center. We had rotations at Children's National Hospital. So I had really good exposure with cleft lip, cleft palate repair, really just diving right into oral surgery. I'm not really someone who treats TMJ. I have my own philosophies about that, but we did everything, including TMJ, orthognathic surgery, trauma, of course, your regular dental alveolar, and we had a clinic, so we would do third molars, just the whole gambit. And I mean, I was totally infatuated at that point. You couldn't tell me anything. My passwords were oral surgery, everything, my whole life, oral surgery, oral surgery, oral surgery. And so since then, I've been practicing maxillofacial surgery for the last 10 years in a DSO. And 3 years before that, I was practicing in private practice in Philadelphia. Currently, 2022, I matched up with Dr. Justin Moody in Tempe, Arizona, USA at the Implant Pathway. Implant Pathway is another really like just a mind machine, a churning of people who are thoughtful and people who are totally involved with surgery and implantology specifically. You know, it's a breath of fresh air to be with general dentists who have the same passions that I do. And I am one of the only oral surgeons who teach at Tempe, Arizona. There's another one, but I think he's only didactic. But to be around other people who have the same energy, it really is just gratifying, and it helps me learn. I'm learning as I'm teaching. And so to the folks out there, Implant Pathway in Tempe, Arizona, really good place to be. A very solid foundation and a solid education. In my private practice, on a routine basis, we do more than 50% of our practice is dental implants, and 90% of the implants are immediate implant placement. If the patient is coming to me, the patient's referred for a tooth to be removed, believe me, they are leaving with an implant. That is just as natural as they come in to buy shoes, they're coming out with a matching belt. It just goes hand in hand because they know by the time they're finished speaking with me how important it is to replace the tooth. They may have been thinking about how much it hurt and how it was keeping them up at night, and it's unsightly or it hurts or something about that, but they will realize that it is most important that they replace it. And so I try to really just drive in the education, the function, the aesthetics of what's going to happen after we take the tooth out. That's the easy part. Most of my patients are sedated. We do provide sedations. We provide full mouth extractions, difficult extractions. Those are my favorites. Impactions, socket grafting, ridge preservation, ridge augmentation, sinus lifts, tori reduction, another fan favorite, tori reduction. Sometimes the tori are so big, they're practically kissing. We allow for the patient to be able to breathe more comfortably. They're able to move their tongue more comfortably, less trauma now that the tori have been reduced. Specifically, third molar extractions, coronectomies, biopsies. So on a day-to-day basis, I don't even know the schedule. I come in and it's kind of like boots on the ground, who's first, get to know them, figure out what their concern is, encourage and educate them, and then move forward. And that's what I hope to express to you all today. Thank you again very much for being here. My purpose today is to show you how easy it is. All right, let's get started. Nothing is impossible. So maybe you're looking at that tooth and you're thinking, gracious, that looks terribly decayed, non-restorable. Clearly, it's tooth number 19. There's a cavity on the tooth adjacent. You have to be very cognizant not to damage that tooth in any way. You really want to make sure that you don't feel intimidated. You can do this. If I can do this, I can teach you how to do this, and you can do this too. In this situation, you certainly want to take your time, make sure you're holding on to the mandible, giving plenty of support. You want to put your finger on the tooth. You're going to start to feel it moving. You want to feel bodily movement to ensure that you don't start breaking it apart. I want you to also notice in the back, you'll see that little circle. That is my purposeful intent of identifying where tooth number 18 will go, because after 19 is removed, we may lose some of our anatomical structures and boundaries. So we just utilize it as kind of like a landmark. Once this tooth 19 is removed, then we can place 18 and 19 as an immediate. When you're using a cow horn, you want to allow for the forceps to wedge right down onto the furcation. You can hear the patient kind of moaning a little bit. That's okay. He's sleeping. You just crank up the music and get the tooth out. You're going to do bodily movement, up and down pumping, and also rock side to side rocking of the 23 forceps. Nothing is impossible. There you go, guys. You can do it. The primary goal of this course is to present clinical guidelines to achieve adequate to ideal bone volume for implant insertion. The process begins with the preoperative surgical planning, atraumatic extraction of hopeless teeth, and tooth grafting, and continues to the use of a barrier membrane and guided bone regeneration. Most important, atraumatic extraction is a must. We don't want to get to a point where you're trying to take the tooth out and you have to damage bone to do so. You're trying to keep as much bone as possible. If bone does come out with a tooth, it's not the end of the day. You know, it's not the end of the world. I'm not a periodontist. Periodontists, they get a little quirky about buccal plate. If the tooth comes out, that's good. But what you're trying to avoid is to not remove any bone as possible. And the way that it sometimes happens is that you're trying to take the tooth out and you will break the tooth trying to conserve the bone. Don't get into that situation. If anything, try to take the tooth out in whole. And if the bone is compromised, well, then keep in the back of your mind, you're going to utilize socket grafting. Spend the extra time to get the extra tools to maintain all host bone. As you can see, I'm using forceps. I'm not a periotome kind of person. Very rarely, if needed, I will surgically remove some bone so that then I have something for the forceps to hold on to. My go-to is also a 69 forceps. Once the tooth is out, degranulate, degranulate, degranulate. Any granulation tissue remnants can spell doom for your graft. You have to clean it out. You're curetting, you're removing any evidence of any granulation tissue. Another pearl would be to utilize a mixture of peroxide and saline. And when you place it into the socket, you'll see it start to bubble. And then you come behind that and rinse it out with saline, and you'll see the granulation tissue. It's almost like it highlights it. It's you can literally see it much more clearly than if it's in a bloody socket. So be sure you are utilizing your irrigation. Irrigate, irrigate, irrigate. The key to pollution is dilution. I'll say that again. The key to pollution is dilution. So if we're in a extraction socket that is previously infected or has infection or was infected, just irrigate. You will get all of this purulence out of the way, clean it, and you can graft it. There's some questions of whether or not you would graft an infected site. Yes, I would graft an infected site because by the time I'm ready to graft, that site is no longer infected. That's a previously infected site. So make sure your walls are clean, no remnants of any granulation tissue. Blood is your friend. I know in some other countries, other places, we have a concern about blood. In this situation, we are doing surgery. Blood is our friend. If the socket is not bleeding, make it bleed. Curette or small perforations with the drill just so that you can get active blood flow. Because remember, the blood is bringing all the BMPs and bringing all the ingredients that we need for healing. Blood is our friend. A dry socket is not going to be helpful in any way. No tension on your sutures, folks. Sutures are not there to pull edges of flaps together. In dental and in residency, we used to say approximate, don't strangulate. Do not be especially aggressive to get it closed. We know that these sites are going to be healing with secondary intention. If they're not together, then there's a slight space. we know that that area is going to eventually heal, might heal a little more slowly, but we don't want to pull the tissue, which can cause more damage like tissue necrosis. Grafting and suturing. The two most important adjunct implant surgical procedures. Success at these two techniques and with continued improvement will increase your comfort and success with all types of surgery. Good grafting techniques can make implant surgery easier, more predictable, and more profitable. So look at the pictures up there. You'll see we really just want to get the wounds closed. They're slightly overdoing it with these sutures, but the point was to let you know that it's important to do your best to make sure that it's closed. So indications for grafting. Why do we do ridge preservation? Well, if the buccal plate is less than 2 millimeters thick, it's important that you want to graft. Grafting will achieve a better aesthetic and functional results. It will avoid ridge shrinkage. It can gain height and width. It will facilitate healing. It can make our lives easier. Think of this paradoxical thought. So if you take the extra steps of grafting the site, then you are giving yourself less time to have to talk to the patients about things like dry socket. Well, it's not going to be a dry socket if you grafted the socket. We're actually aiding for the clot to maintain and stay. This will also aid in faster hemostasis and less postoperative bleeding. Now you don't have to have that extra call 2 in the morning, doc, it's bleeding. Not for sockets that have been grafted. That's a rarity. A grafted socket, the clot will stay. Bleeding is very rarely an issue. You're also eliminating the open wound after extraction. I've had patients who say, so is the wound going to be wide open? What's going to happen? I say, well, why don't we graft it and put bone in there and then cover and protect it, and then you'll feel more comfortable when you eat. You know, put it in their mind that this is the absolute ultimate best care. This is the way to make them feel more comfortable and at ease. You are reassuring them that after a socket has been grafted, then they will have more predictable future implant placement. Just reassure them. Just make it as if this is their idea, okay? There's less postoperative complications and perhaps less phone calls. I do call my patients usually the day after the procedure, like when I'm back at the office. I used to call patients the night of, but now it's usually the day after, back in the office, checking on people that I may have treated yesterday. Another indication is that with sites maintaining volume is critical to minimize risk of involving anatomical structures. So looking at the panoramic at the bottom, this patient came in, he needed 2 teeth removed, and you can see there, site number 3, that the sinus is clearly something that's going to drop down, pneumonize. So you explain to the patient, well, we're going to put bone in now, so we don't have to put bone in later. You know, we may need to put bone in later, but we certainly wouldn't need something aggressive or something that would be more expensive. Let's graft now to avoid needing major grafts later. And that helps the patient understand, okay, we really are doing something to plan for the future. When you graft the maxillary sinus area, you're doing that so that you can eliminate the need for having the implant into this, perforate into the sinus. You're grafting at that site. You also want to keep in mind to graft on the mandible, and you want to graft on the mandible in the area on the bottom, on the bottom left or right, because we want to keep in mind of the inferior alveolar. Okay, so for everyone who's awake, paying attention, I have one question for you. And I would like you to answer it in the chat box. The question is, let's see if I can maneuver this computer. What is the most common extraction socket to be grafted for future implant placement? And I ask you that because I want you to be thinking, okay, well, every tooth that's removed should be replaced with an implant. That's what I believe. If every tooth that's removed is replaced by an implant, can we place it at the time of extraction? And I don't want you to feel defeated or kind of upset or, I don't know, overwhelmed that you didn't get a chance to put the implant in. That you don't take that mindset of disappointment out of your mind, because in reality, you have only set yourself up for positive things in the future. So if you look very carefully at tooth number 31 on the top left, you can see this is a really big tooth. This is some gigantic roots here, and they are convergent. Okay, that's important. If the roots are coming together, then you won't have any space for an immediate implant. If the roots are coming together and you see clearly that the inferior alveolar nerve is running just apical to tooth number 31, this is not the one to be disappointed that you didn't put an implant in. Just graft the site. Just graft it for future implant placement. It clearly was taking up a lot of space. The tooth was taking up a lot of space and affecting your ability to have initial stability. When you are looking carefully on the picture on the top right, you'll see that you can barely see the bone graft material. It's almost like, and this is immediately after. I take x-rays immediately after grafting so I can post them for you all to see them. I don't necessarily need to take the picture. If you want to take a picture because you're learning and you're making sure that things look in good condition, that you have filled the void completely, no problem. I take the picture so I can show you how beautiful it looks after we took the tooth out and have grafted at that moment, and practically looks like a healed socket. I had to outline on the bottom right so you could really even appreciate where the socket is. And also I highlighted the inferior alveolar nerve so you can appreciate that this really was something that needed to be grafted. Don't get confused. Not every site can be an immediate implant. Grafting is important, and it is certainly in preparation for future implant placement. Almost, guys. Okay, good. Okay, so a third indication is when the patient with high aesthetic demands, such as a high lip line or a thin biotype, which is prone to recession, even if they're not doing an implant, graft the site. Graft the site for any reason. There's no reason not to graft a site. If the patient is saying, oh no, I'm not going to get an implant today, just take this tooth number 9 out, the one in a central incisor, left central incisor, small gingival fistula. They say, oh no, I'm not going to get an implant. I can't afford it. Well, they need to be grafted, because one day when they want to throw the flipper out the window, the little false tooth, and they're ready now to decide to put an implant in there, that graft will certainly be helpful. So please, even if you're not intending or the patient doesn't intend to put an implant, graft the site, explain it to them, make sure that they know that this is what's best. And please graft the sites in patients having multiple teeth extracted. And this is very important for preserving bone. You can see here in this image, very little bone, missing teeth, mobile teeth. Graft the site. open everything up, clean out all your granulation tissue, all the tissue that makes this periodontally involved, and just put bone graft everywhere. Top, bottom, left, and right. You can place a membrane, cover and protect the wound. You can have the patient wear their full upper, full lower. Just be sure that you are grafting these sites. Classifications of materials based on the mode of action. Osteogenesis refers to the formation of bone from living cells transplanted within the graft. Osteoinduction refers to the property of material to induce differentiation of undifferentiated peripupal cells towards an osteoblastic phenotype. Osteoconductive and material is analogous to a scaffold or framework into which existing bone cells may grow. When I'm speaking to the patient, I'm a big person to draw pictures. So I'll draw the picture of the empty extraction socket. I'll clearly explain to them that we're going to place an implant at the time of extraction. I'll draw a little bit of dots around the implant indicating that we're going to graft the site. I let them know that the graft material is a scaffolding so that their bone will permeate through and the entire area becomes solid. Pictures are worth 1,000 words, and sometimes they really get it. They say, you know, I say, do you have any questions? No, you explained it very well. They understand bone grafting before they leave. So you want to be able to explain to them how critical and how important it is as well. Autogenous graft. So this refers to a transplant of viable cortical cancellous bone from one location to another within the same patient. So for instance, So for instance, you can take bone from the hip, the ramus, the chin, but that would require a second osteotomy site. Another very good option, sometimes folks don't think about this. If you think of implants as carpentry, I'm talking about if I have to hang something heavy on the wall, like a heavy mirror, first I have to find the stud. Once I find the stud, I'm going to get my drill and I'm going to drill a hole into the wall. When I take my drill bit out of the wall, my drill bit will have drywall on it. Well, the same philosophy goes with implantology. So if you drill a hole into the bone, you take the drill bit out, look very carefully at the picture at the bottom right. You're going to see the assistant meticulously removing the bone material from the drill flutes, and that is autogenous graft. We didn't need a second site. We're just using the site where the tooth has been removed. This is definitely helpful, and it is absolutely going to only benefit our graft material to be more successful. Autogenous grafts include osteoconductive and osteoinductive parts. And then if you look very carefully down at the bottom, you can see a little bit of red in the well of the graft bottle. That is the pieces of the bone that have been harvested from the drill bit. Just scrape them off, add them in, mix them up. Allograft refers to a transplant within the same species, such as human use of demineralized freeze-dried human bone or freeze-dried dermis in human subjects. The most popular graft in the USA is allograft. It provides a scaffolding for bone growth, osteoconductive and osteoinductive, and it's often turned over by the patient's body in 10 to 12 weeks. It yields good bleeding bone upon re-entry for implant placement. So adding autogenous bone graft to your allograft only makes it more successful. And I do want to note a lot of the images that you're going to see here today are going to be grafting material that is a particulate matter. I use particulate matter. But for new people coming to grafting more regularly, you can also be aware that there's such a thing called a bone plug. A bone plug is going to be the combination of the cortical fiber in addition to the particulate, and they mix it up, and now they have a little plug. It's a little bigger than a Tic Tac. It looks a little bit like a small white cylinder, and it fits snugly into the socket. When you use a bone plug, you don't always have to use a membrane. Nonetheless, xenograft refers to a cross-species transplantation of tissue. Bear with me here. Of tissue such as the use of inorganic bovine or porcelain collagen in human subjects. There's a low turnover rate. It never fully matures, and sometimes it's just maintaining the space. Alloplast refers to implantation of a synthetic material such as hydroapatite or tricalcium phosphate, bioactive glass, or polymers. Not only is this very expensive, it doesn't always give us the results that we're looking for. So I just don't recommend it. I just simply wanted you to know that there are several options and exactly what each option is, so that you know if this is something that interests you or if this is something you want to utilize. The classifications of grafting material based on the source, as I mentioned, autograft is osteogenic, osteoinductive, and osteoconductive. Allograft is osteoinductive. It releases BMPs. It's osteoconductive as well. Xenograft, osteoconductive. Alloplast, osteoconductive. And you can add autograft to it so that then it can be osteoinductive as well. The barrier-membrane is going to be a critical part to the steps. When I'm using particulate matter, I want to make sure that I cover and protect the wound. It helps prevent epithelial ingrowth. Epithelium heals much faster than bone. So you don't want the top to be healed and meanwhile the bottom is still soft. So we want to protect the wound so that the soft tissue doesn't heal into the graft, and it allows for the graft material to take its time to heal completely. It also is a space maintenance. It maintains the space to rebuild lost bone. It maintains the graft and holds the graft in place while the clot forms. And it does have different resorptions and different handling characteristics. You can find some membranes that are a little more stiff. You can find membranes that are taper thin, like almost see-through, actually. Okay, let's put all this good information to use, folks. First things first. This is going to be a presentation, a case presentation specifically of a root canal tooth. That's always a challenge. People shun root canal teeth. This is going to then show you bone grafting, immediate implant placement. I just want to show you immediate implant placement so that you know how to graft if you're going to place the implant as well. The presentation itself is about socket grafting, and I hope you're thinking, okay, if we take the tooth out and we can't put an implant, then we would graft it. But this specific case study shows you when we're going to put the implant into. Membrane placement with closure, and then a post-op x-ray. All right. Now, the picture in the middle is the tooth that is not in good condition. This video is in real time. This video shows you that even me, Dr. Extraction Jackson, I take teeth out all day, every day. But what's important is that you always take your time. You know, there's no reason to be rushing or harried or preoccupied or nervous or thinking about other things and why are you taking so long. I put this video specifically, and you'll see, we're going to get the tooth out by the time the video is over. But my purpose here is just to say, take your time. It really doesn't matter how long it takes to take the tooth out. What matters is that you did your best and that you were successful in trying to remove the tooth without damaging other structures. If you look very carefully, the adjacent tooth has a crown on. So you really don't want to elevate too much because you are in danger of possibly knocking that crown off or damaging that crown. Just take your time. You're also putting your mind at ease is to hold on to the maxilla. Just like I showed you to hold on to the mandible, you really want to only be pushing against yourself. You don't want to be pushing against a patient's head that's moving. I don't even really I really won't even accept if my assistant is holding. I want to hold. I'm taking the tooth out. If you're taking the tooth out, you want to be holding to digital pressure. So the one finger is holding onto the maxilla, even the buccal plate, and the other finger is squarely on the palate. It's very important that you are holding on. Sometimes you can even be retracting. Take your retractor out and hold on to the maxilla. You're going to feel every part of this extraction, no matter how long it takes. Even if you take teeth out every day, just take your time, take your time. There was a systematic review that said, it was through PubMed, Embase, and the Central Registration. And they conducted a study all the way up until February 2020, February 2011. It was randomized clinical trials and prospective cohort study with a follow-up of at least 3 months, reporting changes on both the hard and soft tissue. The study showed that if you did not graft the sites, then you were going to have bone resorption. You were going to have at least 1.4 millimeters of reduction for height and 1.3 millimeters in width. You don't want any bone to be lost. So if you can ensure that there's going to be bone for future implant placement, place the graft. Hey, look, I got the tooth out. You see, the tooth is finally out. That took 3 minutes, folks. 3 minutes is really not that long. So take your time. There's no buccal plate on there either. It's all tooth. Just take your time. Take your time. All right. Once the tooth is out, on the top left, you're going to see that we irrigated the socket. We have degranulated. Everything is healthy and in good condition. At this point, I've also put a extender on my handpiece, and I have my pilot drill. I make first osteotomy into the site of the extraction socket. I am going more palatally than I am buccally, even though my buccal plate is intact. Once the osteotomy is made, I'll say occasionally I will check with my paralleling pin, but most of the time I move on to my second drill bit. The picture in the middle shows that now we've elevated past the pilot drill, and now we're actually on to perhaps a 3.2 diameter drill bit, and we are making incremental widening of the diameter of the drill bit to accommodate the eventual implant placement. And then number 3 on the far right is my assistant mixing up my graft material, making sure that it is well hydrated. We then put a small little 2x2 so that we can resorb or absorb some of the extra water. And now I'm coming right over to my implant site. You'll see that there is a paralleling pin in that site. I utilize a perio probe. Sometimes perios come into favor. The perio probe is very useful, the back end and the front end. One, to get the graft material into those little tiny spaces, and then the front end to really just pack it in nicely around the paralleling pin. I think that this is my own technique. I'm not sure where I picked it up in my training, but I don't see a lot of people doing this. So I thought to bring it to your attention so that you can consider it when you're placing implants as well. So the idea is you are not supposed to touch any of the threads of an implant. So my mind was thinking, well, how am I going to get the bone graft there if I'm not supposed to touch the threads? Or I don't want to fill the osteotomy in and then come in behind with the bone. I mean, with the implant, it just seemed like some of the bone graft material would then be removed if I tried to put the implant in within a grafted socket. So after it's packed buccally and lingually, or labially and palatally, completely packed all around the paralleling pin, and make sure that you put a floss on your paralleling pin. You do not want any concerns. I am also a strong advocate of placing a throat pack. There is nothing wrong with a throat pack. It can save your life and someone else's. Okay. Now on the top left, this is the exact moment when, after grafting very carefully around the paralleling pin, I'm going to pull the pin out. And voila, it makes the exact perfect place for me to come now with my implant. I feel very confident and secure that this site is grafted well. All my bony walls are in good condition, and I just come right in with my implant. After I place the implant, I always put my implant motor on 50 newtons. So every single one of the implants I place is at 50 newtons. I very carefully try to disconnect the extender from the driver, and then I will take the driver out and put the cover screw on, and I put it finger tight. You can place it in and you'll feel it just at a point where it won't move any longer. You don't have to overdo it. Don't push it. Just as long as it's finger tight. There's our finger tight. That's my fingers. And then after it's finger tight, I put on the last little scoop of the bone graft material. And then in the middle, you'll see that I'm coming behind and I'm coming to cover and protect the wound. The membrane can be tucked underneath the labial mucosa. It can be tucked underneath the palatal mucosa. It can really just fit perfectly in the bone grafted site. You don't have to overdo it. Don't work so hard on things that don't matter. Work hard on the things that are the big issues. Don't get me wrong, it's important to be meticulous, but you don't have to overdo it. Enjoy yourself, have fun. This is you on stage. This is you taking your time, grafting the site, approximating the wound edges. Someone needs to hold down the membrane so that it's not moving all around, and just take your time to eventually secure the membrane. Very carefully, I use the curette to kind of manipulate the membrane. I always soak the membrane so that it's more malleable. I soak it in saline or sterile water. It just has a little more flexibility to it, ability to be contoured. And then I'll have the surgical assistant to hold the membrane in place. And just take your time. Usually in my office, I'm playing some music. We call it good vibes music on Friday. Depending on the patient, we'll play Jimmy Buffett or we'll play the Temptations. Just make sure that you're in an atmosphere that you don't feel rushed or under stress, and it will help you give quality care to the patient as well. I will also utilize a 2x2 to kind of dab the area. Sometimes suction is a little too aggressive. After I've dabbed the area, I can see the membrane a little better. I can see the sutures a little more clearly. You can actually see the figure 8 over top of the membrane. Finishing touches, we'll suction all of those last little bit of particulate matter. I'll tell the patient that they may taste something grainy like sand at the beach. I tell them that it is just the overfill or the extra bone graft material that they can just rinse away. So this is the before and after. That is our root canal tooth just butting up against the maxillary sinus. And we also have our immediate implant equally butting up just against the maxillary sinus. Okay, case number 2. Oh. Case number 2. This is a failed implant and a ridge augmentation. Mandibular right, implant looks not in good condition. You can see some calculus around the implant. Doesn't even look like it's ever really been restored. Once we opened up the site, we got the implant out. I took it out with a forceps. No need to remove any bone. Just held on to it and rocked it out very gingerly, very graciously. And then it left a pretty significant defect. That defect was present to begin with, so there wasn't anything extra that required bone removal. Cleaning out the area with copious irrigation, making sure there's no granulation tissue, make sure everything is in good condition, bleeding bone. I opened this one up generously. Even I opened it after we got it out. I don't make cuts unless we have to. So once we got the implant out, I opened it only so that I could have direct visualization of the ovule of the ridge. The center little well shows you that I will use every last bit of that bone graft material, even down to the last morsel. And what's also important is that you use very small increments of the bone grafting material. On the picture on the top right, you can see we start with very small increments right down at the most apical part of where the implant was removed. It's important that you use increments so that the entire space is filled well. This would not, in my opinion, this would not be a good fix for a bone plug, because unless you started cutting it up, and then if you're going to cut it up, you might as well just use the particulate. But you want to make sure that you do not have any voids. The picture on the top left, clearly filled to the brim. There's a overabundance of bone material. Be generous, don't be skimpy. And once you have everything filled as much as possible, now there is a membrane that was tucked on the lingual, tucked on the labial, and then sutures to close up the wound. This is a ridge augmentation. This is the before. You can kind of see that defect that started off in the beginning. And again, I only took this post-op x-ray so that you all could see that it is clearly grafted. And as a matter of fact, it looks like it's been grafted for a while. And when I look at the after, all I see is plenty of space for 2 implants in the future. I just wanted to let you know that I have a study club called the First Ladies of Dentistry Study Club. It is women in dentistry. Sometimes folks don't realize that there are that many women of color in dentistry. I just always try to get everyone to come to the same location so we can vibe off of each other and get good information and learn new things. I also have a study club called the Essential Study Club. Similar activities. This one involves inviting the guys too, so we can learn the essentials. And please, everyone, at this exact moment, get your phone and go on Instagram. This is a requirement. And you need to follow me at socket_grafting_girl. I say this is a requirement because daily I am posting pictures so that I can talk to you guys. And don't just follow me. You got to like stuff because I put these pictures out there and I'm wondering if anyone even notices them. Please follow me at socket_grafting_girl. I'm out here. I'm doing this. I want the world to know it's not tricky. And sometimes I'll throw in a picture of tori reduction, or I'll throw in a picture of some strange biopsy. So I do try to keep people interested. Coming soon, Tooth Titans DSO and the International Implant Institute with Dr. Anarobi and Dr. Haroon. Coming soon. I'll give more details when we know more to talk about. Again, it will be an implant prosthetics mini residency. We are thinking it will start in July 29th to August 2nd. And there will be multiple courses in the future. Keep in touch with Dr. Anarobi. Keep in touch with Dr. Anarobi. Okay, let's go to number 18. That is bottom left, second molar. This one is going to be socket preservation. Not everyone is capable of getting an implant at the time of extraction. In my practice, implants can be pretty pricey. So we do encourage the patients to prepare the site for future implant placement. In this situation as well, the inferior alveolar nerve was running high, so we delayed implant placement. Okay. When you cannot place the implant on the day of the procedure, please place bone graft material. I'll have my assistant prepare it. He brings it over. This one is a little more material in the first serving. It doesn't have to be such a small increments. And then, of course, at that point, we do pack around we pack the bone graft material down into both sockets. Ridge preservation, sometimes called alveolar socket grafting, is grafting of an immediate extraction socket to prevent the collapse of the ridge, which would likely result in an aesthetic or functional defect. So just to reiterate, it's a lot of different words saying the same thing: ridge preservation, socket preservation, ridge augmentation. Sometimes ridge augmentation sounds like a bigger space, like the last one, which was the implant and the edentulous space. Just simply letting you know that it is grafting at an immediate extraction socket to prevent the collapse of the ridge. Follow me on Instagram at socket_grafting_girl. Follow me on Instagram. I always add music to them too. I want to see my Instagram blow up, folks. I'm ready. Good to the last drop. Okay. I have a question for you. Please enter your answer in the chat box. Question is, how should patients keep the site clean? What are you going to tell them with regards to postoperative care? Are you going to tell them, A, rinse with Listerine, B, rinse with peroxide, or C, rinse with salt water? If you look at the picture on the top left, you can see that this site now has the membrane placed. The membrane is contoured to the site. My assistants usually cut it into maybe a large oval. Either way, I do trim the edges and make it so that it'll fit nicely into the site. The image in the middle is holding down the membrane as the assistants are the assistant is holding down the membrane as I'm coming behind with the suture. And then the picture on the top right shows that the sutures do a figure 8 over top of the membrane to hold the site in place. I tell the patients they can't do anything to hurt the site. They need to eat. They should eat anything they want. They will not damage the wound. I want them to feel comfortable to eat so that then they can take pain medication if necessary, and also to help make sure that they stay healthy with regards to their nourishment. My recommendation is only salt water rinses. I tell them to rinse with warm salty water 4 to 5 times a day. To even get a plastic water bottle, Deer Park, put salt in it so that they can take gulps and swish, 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 and remove any excess bony material. Also helps facilitate the wound healing. Warm salt water 4 to 5 times a day for the next 4 to 5 days. And I absolutely do not agree with Listerine, peroxide, no fancy mouth rinse. I tell patients I'm not really concerned with fresh breath. They're like, what? I'm like, yeah, I just want the wound to heal. And then you guys can get into your fresh breath regimen. Complications of bone grafting. So the only thing I could think of was that there would be insignificant bone. I found this x-ray and it says not getting bone graft to fill the socket. This is when I am meticulous, is when I am making sure that each increment of bone fills in the spaces completely. This picture on the bottom right is horrific. This should never happen. This is a no. You need to, if you take the x-ray and it looks like this, sit the patient down and let them know that you're going to make some minor adjustments. And the minor adjustment is you need to graft the site because that looks horrible. You didn't get any bone down to the apical portion of where the tooth used to be. And that's exactly where the bone graft needs to be. So in my opinion, absolutely, you want to be mindful of making sure that the graft is placed diligently at the most apical point of the socket. And this is not like amalgam, so you don't want to over condense. You just want to make sure that you visualize that it even got down to the bottom, and then small increments, maybe utilizing the perio probe, whatever you can get, so that you can get all those little bone particulate matter down to the last part of the socket. Another complication I thought of could be that there could be an infection, but in my office, we certainly do give patients antibiotics. The antibiotic of choice is amoxicillin. 500 milligrams, 21 tabs, and they'll take it TID. If they have allergy, I'll consider clindamycin or Cleflex or doxycycline. But antibiotics are very helpful and absolutely should be given. Moving right along, now I'm going to make it more complicated. This time we're taking out 2 teeth. We want to be mindful of possible maxillary sinus precautions. In addition, we're going to be grafting the socket and placing a membrane. So on the top right, teeth numbers 2 and 3. Excuse me. On the top right, we're taking out teeth number 1 and 2. Sorry. And we are removing them because, well, they're not in occlusion. Also, we're removing them because they are super erupted. We're removing them because the general dentist referred them to us to have them removed. We see that the roots are penetrating through the maxillary sinus. And so these are all the reasons why we would want to have the patient graft the site. It may not be for future implant placement, but it certainly is in preparation of making sure that the sinus doesn't become an issue. Okay, hold on. Okay, well, that was it. So there's the 2 teeth. They're out. Didn't take 3 minutes for that one. And now this situation is really just to show you taking your time to graft the site. This one, I'm using a new instrument I'd like to bring to your attention. It's called a packer. The packer is here because it can put larger quantities of bone graft material. We don't need the perioprobe in this situation, not that delicate. Really just get all the bone graft material in. There may be some excess. You utilize the gauze to remove any liquid so that you have good visibility. I just want to emphasize, extract the tooth, clean the site, graft the site, suture over the site. That's it. 4 steps. You know, if this was cooking, extract the tooth, clean the site, graft the site, suture the site. That's it. 4 steps. And this is the 4th step where the site is sutured. There's our post-op image. Looks excellent. Now, I can't give a presentation without bringing something new to the table. Here's something new. Consider this, a vestibular approach. So I went to one of these oral reconstruction foundation meetings. I met Dr. Eschieri, who I believe is a dentist in Egypt, Alexandria. And he was telling us about this approach, and it took me a minute to really appreciate it, but I will bring it to you today. Tell me what you think. So this is a patient in my office, and tooth number 12, not just that tooth number 12 was missing, but I believe that this was a failed implant site, and it left a defect that looks horrible. And I thought, you know, this would be a great opportunity to utilize a new technique. Dr. Eschieri's technique is called vestibular socket therapy. If you look on the bottom left, we can see our defect. It's a bony defect. It's a soft tissue defect. The site looks collapsed. In the picture in the middle, you'll see that actually we made an incision above the defect. This is not a crestal incision. This is an incision made in the vestibule, just above the apex of where the root would be. And if you look to the picture on the right, bottom right, I'm going to play it. I'll talk while it plays, but I'll play it twice. And you make an incision and you're kind of tracking down into that defect. I'm holding the tissue down. My assistant is coming behind me with a little bit of bone, small increments. And we're bringing the bone graft material to fall into the defect. We didn't have to place a membrane. Everything was incorporated and encapsulated into that small envelope that was made by reflecting the tissue off of the defect. I reflected the tissue off of the defect on the labial and all the way over onto the other side palatally. And I grafted. This is socket grafting, just a different approach. One more time, I'll show you how you can kind of push it in, move it around, and pack it down. Thank you, Dr. Escari. And the post-op looks beautiful. So you can see on the top left, that is with the tooth that has a cavity in it, but you can start to appreciate the bulge of the bone graft material. And now you're moving in the middle one to the actual edentulous site. You can see the bone graft material on the palate, and on the picture on the top right, you can see the bone graft material also on the labial aspect. So the entire defect was filled in very nicely for future implant placement. Okay. This one is for the ones who like a challenge. Okay, so last one was 2 teeth, something new. This one is for the folks who are ready for something that's not going to just walk in every day. This is retained primary tooth. This man was approximately 60 years old and he had a retained primary tooth. His goal was that he wanted to close all the spaces, and if that included braces and future implant placement. Well, one of the spaces was the retained primary tooth. And then the other part to this is that the retained primary tooth was present because the adult maxillary tooth was impacted, number 7. There was also something on the image that looked questionable, which we did biopsy it, and it turns out it is a sclerotic bone. That was the pathology report. We knew we would be involved with poor wound healing because he was diabetic and had very elevated blood sugar. We didn't know we would come across tissue necrosis, but I want to show you what are some of the things that can happen. This required secondary wound healing, and there was also the question of whether or not there would be a possible nasal oral communication. All right, so January 2022, 1 year ago. Patient presented to the office. You can see the retained primary tooth, top right of the patient. My CT scans allow me to also decrease the density of the bone. So when we remove some of the bone, we can see that there's something in that area on the maxilla, top right, above the retained tooth that we just call question mark. So it was kind of like, okay, well, we're going to remove the tooth, we'll remove that, whatever it is, and we'll send it to pathology. Well, lo and behold, if you look especially carefully, you'll also see that there's tooth number 7. This is the ones that they send to me, and this is why I get up in the morning, because I'm like, wonder what we have today. So tooth number 7 clearly rubbing against the floor of the nose, possible nasal communication. And so the idea is, if we take this tooth out, certainly do want to graft that site. Well, it didn't go so smooth. I'll say this. I don't think the flap was as nicely done as it could have been, but in reality, I don't think the flap was the problem. So the blood supply is fine. Clearly, it's a bloody mess, but the flap was thin, easily friable, which is kind of odd because for palatal tissue, it's usually a little more tough. We reflected the tissue. You can see the hole. Fortunately, we were able to remove the sclerotic bone. I did get a good biopsy specimen. I was able to remove the retained primary tooth. You can't really see it, but believe me, there's a socket up there. And the reason this hole is so big is because I was digging to go get tooth number 7. But again, the blood supply was adequate. This was not a dry area. The procedure itself took place on February 10th. The January was just the consultation. So now it's February. After the procedure, you can see that the graft material is present. This is a 3D image. You can see on the left side that we grafted even in the palate. We grafted on the labial portion of the site. We grafted everywhere. There was bone everywhere. And everything closed up very nicely. And then he came back 7 days later and it looked like this. His wife was highly upset because her concern was his breath. And I'm thinking, again, I'm not concerned with fresh breath. I just want the wound to heal. Don't be alarmed. Yes, we grafted the site and we also put a membrane. So what you're really looking at is the membrane. I do think it's because of the friable maxillary tissue. It probably did have an odor. This is tissue necrosis, and the patient was not having any pain. He just simply, let's just say, wasn't comfortable eating. It wasn't that it hurt. It wasn't comfortable eating, and I can understand that. On February 22nd, the necrotic bone had fallen out. It could happen to you as well. Do not be alarmed. Time heals all wounds. Finally, the necrotic bone fell out. I'm sure the odor was much better. I then, at that point, did give him a bottle of Paradex so that he could continuously irrigate the wound. But I also wanted to give him something so that he wouldn't get any food into the site. And the idea was, let's do a suck down. A suck down is a model, and we put the model on the machine so that a plastic tray can be made. We put material into the void so that the suck down didn't go into the void, but actually laid flush to the wound. After he started wearing this suck down, he was very happy. Everyone was happy. The wife was happy again. And now March 24, he's looking much better. He had been wearing his suck down. I forget what we called it, not a occlusal guard, but like a
S6.
A stent. What did you say?
I said S6.
S6, okay.
Yeah,
S6 is
stent, X6, yeah.
a stent. Yeah, but stent. So S6 usually in my mind has teeth on it. This was no extra tooth there. It was just to cover the roof of the mouth. But thank you, Dr. Honorable. Yes. A stent is reasonable explanation. So it's getting better. Well, lo and behold, he disappeared. He absolutely disappeared with the hole in his the hole in the palate. Patient was admitted to the hospital due to diabetes. His diabetes was not under control. Perhaps, maybe not perhaps, but absolutely contributed to the tissue necrosis, absolutely contributed to poor wound healing. Maybe it really wasn't my flap, could have been the combination of the two, but he was lost. And of course, this is the kind of ones where you think about them at night, like, I hope he's okay, wonder where he's going. There was never a nasal oral communication. So even though I did remove tooth number 7, when he was drinking water, it was not coming through his nose, which is always a positive. Sometimes an nasal oral communication can make things even more of a problem when it comes to healing, because now it has to heal from both sides. At least now we knew it was just the palatal aspect that needed to fill in with bone. So this is about March. He disappeared. Here's my guy. May 5th, 2022, and looking good. This I consider success. It might not be perfect, but he can eat. His wife is not concerned. He is not wearing this palatal splint. We took out tooth number 7. This pathology is gone. The primary tooth is gone. You know, on the things to do, I put a check. I grafted the site, so I know there's some bone in there. And now his next steps, which was his goal, which is to now start closing spaces, which at 60 years old, he's going to start closing these diastemas. Good luck, ortho. When he comes back around, then we can put in an implant at tooth number 7, site number 7. I'll keep you posted. Okay, so saline or sterile water is used to rehydrate the bone material. In this image, you can see the assistant picked up a little saline syringe, added the water to the mix, adding the water to the bone particulate matter, mixing it up so that it is a nice gelatinous or cohesive material. And once they have mixed it well, they take out any extra irrigation. And now when they bring it over, they can put it, excuse me, they'll carry it over on the periosteal elevator in small increments, and then I deliberately place it into the socket. I did want to bring to your attention that arrow right there at the membrane at the bottom. I do allow for the membrane to soak in the top of the bone graft material, allow it to soak in the saline or sterile water. Again, making it more malleable, easier to work in my hands. I also use the same periosteal elevator, and I will demarcate or mark on the membrane where I want the assistants to cut the membrane. Actually, if you look real carefully on that, it might not have been the large rectangle. It could have been really that I needed the small rectangle at the bottom, maybe site number 4 or 13, second premolars. It really is just so that I can show them, okay, please cut here, and then I'll work with what they produce. Okay, folks, true or false? Can you hydrate your graft material with local anesthetic? Have you ever been in the surgical suite? You're moving pretty quickly. Someone gives you a tray of bone graft material, and you have your syringe in your hand, and you turn and you put local right in the bone graft material. Why or why not would you ever put local anesthetic in your bone graft material? Okay. On my surgical table, we have 1 cc. That's the picture on the left. You'll see the little canister of the bone graft material. It doesn't always come into the little dish. Sometimes it is a canister. I have 1 cc or 0.5 cc of allograft. I'll have a membrane and a variety of implant sizes. Okay, wrapping up. This is a patient who said, I promise I'm coming back. I promise I'm coming back. Maybe I took out 1 tooth. I'm like, okay, see you later. No, I promise I'm coming back. I'm coming back. Well, she came back for full mouth rehab. I said, okay, well, you came back. Her teeth where every other tooth was not in good condition. If the first time I met her, it probably looked like this too. And maybe it was 1 tooth that needed to be removed. And she says she's coming back. And I'm thinking, okay, we'll see. She was walking around with this 2-tooth partial for the anterior mandible, which looked horrible. Rampant decay, just a mess. The plan was to have teeth removed, and then she was going to wear a full denture, upper and lower. We took out every tooth, and my point to you is that when you take out every tooth, make sure you graft the sockets. On the top left, you can see that the sockets have been grafted. We are now doing some wound closing. On the bottom, you can see the graft. You can see all the graft material. You can also see the membrane, and you can also see that the sockets have been irrigated and degranulated and prepared for bone graft material. If you graft the sockets, you will have more ridge width and height, close to 2 millimeters, by grafting at the time of extraction. Do your patients a favor. Graft the sites at the time of extraction. It's also important that you document all of your cases. Take pictures. I do, but I do think it's important, and this is my note to you all. This is the patient that's the previous picture here, okay? This is her full upper, full lower. Well, the thing is, I do not want to see my assistant's fingers in there. I don't want you to have fingers in your pictures. You should document your cases. Make sure you get cheek retractors. The lips and mouth will be numb after surgery. She could barely open her lips to show us her new smile. Be sure you get some retractors. If you have any questions about retractors, I got some great ones off of Amazon. My preference is metal cheek retractors, not the plastic ones. But make sure you have retractors so that you can properly document your cases. That's it. We made it. Few last minute things. I just wanted to ask a question out there to all those that have been listening, and I appreciate all of your participation. Question is, when you are placing an immediate implant, do you place the implant in the mesial root socket, the distal root socket, or in the interradicular bone? And the answer is interradicular bone is your target. You want to hit right in the middle. Please follow me at Instagram, on Instagram at socket underscore grafting underscore girl. You can also find me at extractionjackson.com. I was Extraction Jackson before I was socket grafting girl. And you can always email me if you have any questions. I am married and I do have a handsome young son. Thank you all for your participation. I appreciate everyone coming this evening. Thank you, Dr. Honorobie. It has been quite the pleasure.
Dr. Jackson, it's been a wonderful time here today. We do have some questions, and I would like for us to, at this point, take those questions. Yunus, so I'm going to start with did you discuss the poll, the results of, can you see this? Can you see this?
I can.
What's the most grafted site for future implants? What was the?
What did everyone say?
63% said second premolar.
No. Is that the highest number? Was there another number?
Yes, and then about 37% said. So the option was the second premolar, second molar. Was that second molar or first molar?
Second molar.
Okay, second molars. 37% said second molar.
So the answer is second molar.
Okay.
You highly unlikely that you need to. It's highly unlikely that you would need to graft the second premolar site because you can place an implant in the second premolar site. There's very little anatomical boundaries. Like you're not going to really be in the sinus, certainly not going to be concerned with inferior alveolar nerve. But the second molar, the inferior alveolar nerve runs high. So from my experience, I have grafted more second molars than second premolars. So my answer is second molar, 31 and 18.
Is there any literature is there any articles that say same?
I can find out. You've
Okay.
given me homework.
Anyway, I'll just piggyback on, and I thought I saw a comment there. Somebody said the first premolar. We do have Dr. Leroy Houghton here, periodontist. He's asked a couple questions. We'll go there now. The next one was let's see. How to keep the site clean.
Good. Okay, so
most people, 75% said salt, salt
good.
water.
Good. 75%, good. You don't need anything fancy. Keep it basic. Salt water heals all wounds. Really, we don't want anything that's going to be especially aggressive to the wounds. Sometimes Listerine has a high alcohol content. I'll have patients who say, "Oh, I'll get the Listerine with no alcohol." Just use salt water. We don't have, there's no alcohol in salt water. So don't make it more difficult. Don't buy something. Salt water, salt water, salt water.
All right. And the one on hydrating the graft, obviously 90% said it was false to hydrate with local anesthetic.
Good. Did anyone say why?
There was a reason here. Dr. Houghton did the pH.
Oh, good.
6, and somebody talked about vasoconstriction. That
yes.
The vasoconstriction there would, obviously you want blood there. You don't want,
Good. We have some thinking people out there. Thank you.
Okay, pretty much. Anyway, we can go to the Q&A. Are you able to see the Q&A? There are about 10 questions on there. If you could.
So Dr. Honorable, let's not do 10 questions. Can we do 5?
Okay, we'll just pick. I know it's time. The rest of it we can answer, through communication.
Okay.
But the first question from Nathan Akimi. Nathan Akimi is from Nigeria. By the way, we have folks from everywhere on this webinar today.
Gosh.
I have Saudi Arabia, from India. Please, I see Ethiopia, Nigeria. There are so many other countries here. Please just indicate where you are watching from, if you don't mind. But it says, Akimi, Dr. Akimi, said, is it wrong to place the implant immediately after extraction and then graft? I guess you would have answered that question in the course of it.
Let's think about the question. Is it in... Can you read it one more time?
Is it wrong to place the implant immediately after the extraction and then the graft?
So that order of operations is not correct. So the order of operations is the extraction and then the graft. So if you're trying to put the implant, then you're going to extract and then you graft. And the way I do it is I'm grafting around the paralleling pin, and then I take the pin out, which is a space maintainer, and then you put the implant in. So the question is, can you extract and put the implant in and then graft? You're going to have some difficulty trying to get the graft material around the implant and in its entirety.
Okay. All right, I'm going to take another question here. It says, Dr. Leroy Houghton's question is, given you said everyone gets, do you consider any contraindications, such as uncontrolled perio, occlusion, rampant decay, and poor oral hygiene? Will any of those things prevent you from, you say, okay, this person shouldn't get?
I graft every single person. If they're ready, I'm ready.
No, he was talking about implant placement, not grafting. Any
Oh, well,
contraindications to implant placement?
yes, some of those are contraindications to implant placement,
Okay.
but
Good,
they
good.
are not contraindications to grafting. And that's what we're talking about today.
Two more questions and we'll call it a day. You said the large
Okay,
particles versus small particle. What was the effect on
good,
on bone formation?
good. I don't know. I have no idea. So you're asking, the question is the particle size, the particulate size.
Yes.
I do not know if there is a difference. I also don't know if different graft materials come in different particulate sizes and what would be the indication for each. That is an excellent, good question. I'll put that for my homework, particulate size differences.
Okay. Okay. We're going to pick one last question here. Dr. Kwaku, greetings to all my folks from Ghana. There's so many people from Ghana. The Dean of the Ghanaian Dental, the acting Dean, is on this webinar today. Dr. Sandra Hewlett, is good to see you here. So I'm going to take this question from Dr. Kwaku answer. I said, do we still maintain the regular post-extraction instructions after
Yes,
grafting? No rinsing, no spitting, and all that?
yes, absolutely. Good question. Yes, we maintain the same postoperative postoperative regimen. I tell the patient not to be rinsing until the following day. Excellent question. I do also, just to be in line with the instructions, no straws. Of course, the straw issue is about not getting the clot to be dislodged. And when you are grafted, you're not going to have the clot to be dislodged. But for the sake of simplicity, no straws. Certainly do encourage that they put ice on their cheek if necessary. They should maintain brushing all of their teeth. They don't necessarily have to brush the site. And they need to take their antibiotics and pain medication as prescribed.
All right, all right. Thank you so much. I believe that this webinar has been